Welcome everyone to my presentation on small for gestational age, premature neonate discharge criteria and follow to up. I am Birhanu Alehegn, pediatrics, and child health resident. Reference I used for the presentation is from Nelson Textbook of Pediatrics 21 edition chapter 117. Keywords in the presentation: early preterm, moderate preterm, IUGR, SGA, developmental delay. The followings are the outline of the presentation. Follow me. Outline: moderate and late preterm infants, term and post-term infants, small for gestational age, and IUGR, large for gestational age. Post-term infants follow to up of high to risk infants after discharge, sequelae of prematurity. Developmental follow to up and developmental delay assessment. Moderate and late preterm infants. Who defines moderate to late preterm? Birth infants born between 32 and 36 and 6 days post-menstrual age. The American College of Obstetricians and Gynecologists further defines late preterm infants as those born between 34 and 36 weeks plus 6 days post-menstrual age. Moderate preterm infants are between 32-week and 33-week plus 6 days post-menstrual age. Moderate preterm infants are still at risk for most postnatal morbidities, although to a lesser extent than very preterm infants are at risk. These morbidities include but are not limited to poor feeding, weight loss, respiratory distress syndrome, risk of NEC, and difficulty with thermoregulation. Moderate preterm infants with birth weight greater than 1,500 gram and a fairly unremarkable NICU course are thought to be at fairly minimal risk for IVH and do not routinely need a head ultrasound. Research has examined moderate preterm infants as an isolated group. More often these infants are grouped with very preterm infants when assessing complications and outcomes. A cohort of approximately 7,000 infants born between 29 and 33-week gestational age were found in a recent study to have a mean hospital stay of 33.3 days. Compared with term counterparts, these infants had an increased incidence of many morbidities, including BPD, early to and late to onset sepsis, NEC, and PVL. Late preterm infants account for approximately 8–9% of all births and almost 3/4 of all preterm births in the United States. Historically, late preterm infants were referred to as near-to-term infants, and the approach to their care was similar to that of term infants. It has been increasingly recognized that late preterm infants have significantly increased morbidity, as well as mortality, compared with their term counterparts. There is an increased incidence of congenital anomalies in preterm infants, but even when these infants are excluded, late preterm infants continue to have significantly more morbidities. Immediately after birth, late preterm infants have an increased risk of requiring resuscitation, as well as increased incidence of hypoglycemia, respiratory distress, apnea, feeding difficulties, and jaundice. They also have a higher rehospitalization rate compared to their term peers. Antenatal corticosteroids were traditionally only recommended for pregnant women between 24 and 34-week gestation at risk of preterm delivery within the next 7 days. To reduce the incidence of death and respiratory distress syndrome, a randomized controlled trial of women at 34 to 36 plus 6 weeks of gestation at risk of preterm labor found a decreased rate of respiratory complications in the newborns whose mothers received antenatal corticosteroids. An increased rate of neonatal hypoglycemia was seen in the steroid group as well, but no other significant differences were found. Based on these findings, American College of Obstetricians and Gynecologists recommends a single course of antenatal corticosteroids for pregnant women between 34 and 36 plus 6-week gestation at risk for preterm birth within 7 days. who have not received a previous course of antenatal corticosteroids. Between 34 and 36 week and 6 days gestation is regarded as a critical period for growth and development. In the past, elective deliveries without medical indications often occurred as early as 35 week. American College of Obstetricians and Gynecologists recommends elective delivery without medical indications only after 39-week gestation in well-to-dated pregnancies. Some studies suggest a higher risk of lower school readiness at kindergarten and increased risk of academic difficulties in childhood comparing late preterm infants with term peers. Good, now let us look on term and post-term infants. American College of Obstetricians and Gynecologists further divides term infants into subgroups: early term, 37 to 38 and 6 days, full term, 39 to 40 week and 6 days, and late term, 41 to 41 and 6 days. Many risk factors for term infants put them at higher risk for complications, such as meconium aspiration syndrome, hemolytic disease of the newborn, infant of a diabetic mother, and neonatal abstinence syndrome. Both small for gestational age and large for gestational age are associated with increased morbidities. Small for gestational age and IUGR. There is an important distinction between the terms small for gestational age, and intrauterine growth restriction, IUGR. Small for gestational age is based on physical evaluation of an infant at birth, usually by a pediatrician or neonatologist. If the infant's weight is less than 10 th percentile, the infant is small for gestational age. The diagnosis of small for gestational age does not differentiate between normal biologic growth potential and a pathologic or growth to restricted state in utero. In contrast, IUGR is a prenatal diagnosis to describe a fetus who fails to reach in utero growth potential, often diagnosed by the obstetrician. Therefore, not all infants with IUGR are small for gestational age, and similarly, not all infants who are small for gestational age have IUGR. Although it is important to understand the difference between small for gestational age and IUGR, due to difficulty standardizing a classification of IUGR, many studies evaluate based on a diagnosis of either small for gestational age or IUGR. IUGR is associated with medical conditions that interfere with the circulation and efficiency of the placenta, with the development or growth of the fetus, or with the general health and nutrition of the mother. Many factors are common to both prematurely born and low birth weight infants with IUGR. IUGR is associated with decreased insulin production or insulin-to-like growth factor action at the receptor level. Infants with IGF-1 receptor defects, pancreatic hypoplasia, or transient neonatal diabetes have IUGR. Genetic mutations affecting the glucose-to-sensing mechanisms of the pancreatic islet cells result in decreased insulin release, loss of function of the glucose-to-sensing glucokinase gene, and give rise to IUGR. Factors often associated with intrauterine growth restriction: fetal chromosomal disorders, chronic fetal infections, cytomegalic inclusion disease, congenital rubella, syphilis, congenital anomalies syndrome complexes, irradiation, multiple gestation, pancreatic hypoplasia, insulin deficiency, production or action of insulin, insulin-to-like growth factor type I deficiency, placental decreased placental weight, cellularity, or both decrease in surface area, villus placentitis, bacterial, viral, parasitic, infarction tumor, chorioangioma, hydatidiform molly, placental separation, twin transfusion syndrome, maternal/paternal toxemia, hypertension or renal disease, or both, hypoxemia, high altitude, cyanotic cardiac or pulmonary disease, malnutrition, micronutrient or macronutrient deficiencies, chronic illness, sickle cell anemia, drugs, narcotics, alcohol, cigarettes, cocaine, antimetabolites. IUGR may be a normal fetal response to nutritional or oxygen deprivation. Therefore, the issue is not the IUGR but rather the ongoing risk of fetal malnutrition or hypoxia. IUGR is often classified as reduced growth that is symmetric, head circumference, length, and weight equally affected, or asymmetric, with relative sparing of head growth. Symmetric IUGR often has an earlier onset in the first trimester of pregnancy and is associated with diseases that seriously affect fetal cell number, such as conditions with chromosomal, genetic, malformation, teratogenic, infectious, or severe maternal hypertensive etiologies. It is important to assess gestational age carefully in infants suspected to have symmetric IUGR because incorrect overestimation of gestational age may lead to the diagnosis of symmetric IUGR. Asymmetric IUGR is often of late onset in the second half of pregnancy, demonstrates preservation of Doppler waveform velocity to the carotid vessels, and is associated with poor maternal nutrition or with late onset or exacerbation of maternal vascular disease, preeclampsia, chronic hypertension. Table 107 Problems of infants small for gestational age or with intrauterine growth restriction *. Problem: pathogenesis, intrauterine fetal demise, hypoxia, acidosis, infection, lethal anomaly, perinatal asphyxia, decreased uteroplacental perfusion during labor, chronic fetal hypoxia to acidosis, meconium aspiration syndrome, hypoglycemia, decreased tissue glycogen stores, decreased gluconeogenesis, hyperinsulinism, increased glucose needs of hypoxia, hypothermia, large brain polycythemia 2. Hyperviscosity, fetal hypoxia with increased erythropoietin production, reduced oxygen consumption / hypothermia, hypoxia, hypoglycemia, starvation effect, poor subcutaneous fat stores, dysmorphology syndrome, anomalods, chromosomal to genetic disorders, oligohydramniosito-induced deformation, TORCH. Large to gestational to age infants. Infants with birth weight greater than 90th percentile for gestational age are called large. For gestational age, neonatal mortality rates decrease with increasing birth weight until approximately 4,000 gram, after which they increase. These oversized infants are usually born at term, but preterm infants with weights high for gestational age also have a significantly higher mortality than infants of the same size born at term. Maternal diabetes and obesity are predisposing factors. Some infants are constitutionally large because of large parental size. Large for gestational age infants, regardless of their gestational age, have a higher incidence of birth injuries, such as cervical and brachial plexus injuries, phrenic nerve damage with paralysis of the diaphragm, fractured clavicles, cephalohematomas, subdural hematomas, and ecchymosis of the head and face. Large for gestational age infants are also at increased risk for hypoglycemia and polycythemia. The incidence of congenital anomalies, particularly congenital heart disease, is also higher in large for gestational age infants than in term infants of normal weight. Post-term infants. Post-term infants are those born after 42 completed week of gestation, as calculated from the mother's LMP. Historically, approximately 12% of pregnancies resulted in delivery after 42 weeks. However, with current evidence suggesting that both morbidity and mortality increase significantly after 42-week gestation, obstetric interventions to induce labor often occur before 42 weeks, resulting in a decreasing rate of post-term births. The cause of post-term birth or post-maturity is unknown. Post-term infants often have normal length and head circumference but may have decreased weight if there is placental insufficiency. Infants born post-term in association with presumed placental insufficiency may have various physical signs. Desquamation, long nails, abundant hair, pale skin, alert faces, and loose skin, especially around the thighs and buttocks, give them the appearance of having recently lost weight. Meconium to stained nails, skin, vernix, umbilical cord, and placental membranes may also be noted. Common complications of post-maturity include perinatal depression, meconium aspiration syndrome, persistent pulmonary hypertension, hypoglycemia, hypocalcemia, and polycythemia. Infants born at greater or equal to 42-week gestational age experience approximately 3 times the mortality of infants born at term. Mortality has been greatly reduced through improved obstetric management. Data suggest that elective delivery during the 39th week of gestation for both nulliparous and multiparous women is associated with decreased maternal and neonatal complications compared with those who were expectantly managed. Careful obstetric monitoring, including non-stress testing, biophysical profile, or Doppler velocimetry, usually provides a rational basis for choosing one of 3 courses: non-intervention, induction of labor, or cesarean delivery. Induction of labor or cesarean birth may be indicated in older primogravidas greater than 2 week beyond term, particularly if evidence of fetal distress is present. Medical problems in the newborn are treated if they arise. Follow-up of high-to-risk infants after discharge. Discharge from the hospital. Numerous criteria need to be met before a high-to-risk infant is ready for discharge from the hospital. Before discharge, infants should be taking most or all nutrition by nipple, either bottle or breast. Some medically fragile infants may be discharged home while receiving gavage feedings after the parents have received appropriate training and education. Growth should be occurring at steady increments, with a goal weight gain of approximately 30 gram per day. Temperature should be stable and normal in an open crib. Infants should have had no recent episodes of apnea or bradycardia requiring intervention for at least 5 to 7 days prior to discharge. Stable infants recovering from BPD may be discharged on a regimen of home oxygen given by nasal cannula as long as careful follow-up is arranged with home pulse oximetry monitoring and outpatient visits. All infants with birth weight less than 1,500 gram or gestational age less than 0 week at birth should undergo an eye examination to screen for retinopathy of prematurity. If born preterm, hemoglobin, or hematocrit should be determined to evaluate for possible anemia of prematurity. Every infant should have a hearing test before discharge. Routine vaccinations should be given based on chronological age before discharge. In addition, palivizumab, Synagis, should be given to eligible infants during respiratory syncytial virus season immediately before discharge for prophylaxis against RSV, with continued monthly doses arranged as an outpatient as appropriate. Table 117.8 Readiness for discharge of high-to-risk infants. Criteria: resolution of acute life-to-threatening illnesses, ongoing follow-up for chronic but stable problems, bronchopulmonary dysplasia, intraventricular hemorrhaage, necrotizing enterocolitis after surgery or recovery, ventricular septal defect, other cardiac lesions, anemia, retinopathy of prematurity, hearing problems, apnea, cholestasis, stable temperature regulation, gain of weight with enteral feedings, breastfeeding bottle feeding, gastric tube feeding, free of significant immunizations, and planning for respiratory syncytial virus prophylaxis if indicated, hearing screenings, ophthalmologic examination if less than 30 week of gestation or less than 1,500 g at birth, parental knowledge, skill, and confidence documented in administration of medications, diuretics, methylxanthines, aerosols, etc. Use of oxygen, apnea monitors, oximeters, nutritional support, timing, volume mixing, concentrated formulas, recognition of illness and deterioration, basic cardiopulmonary resuscitation, infant safety, scheduling of referrals, primary care provider, neonatal follow-up clinic, occupational therapy/physical therapy, imaging, head ultrasound, assessment of and solution to social risks. If all major medical problems have resolved and the home setting is adequate, premature infants may then be discharged when their weight approaches 1,800 to 2,000 grams. They are greater than 34 to 35 week PMA, and all the above criteria are met. Parental education, close follow-up, and healthcare provider accessibility are all essential for early discharge protocols. Ideally, the primary caregivers for the infant have a chance to provide infant care in the hospital with nursing supervision and help before discharge home. All high-to-risk infants should follow up with their primary care provider within a few days of discharge. Post-discharge follow-up, medical follow-up even after discharge from the hospital. High-to-risk infants need very close medical follow-up. They continue to be at increased risk for poor weight gain and failure to thrive. In the setting of viral illness, premature infants are at increased risk for significant respiratory distress. Infants who are sent home on oxygen need very close medical follow-up with frequent visits and assessments, often with pulmonology. Sequelae of prematurity: immediate late hypoxia, ischemia, intellectual disability, spastic diplegia, microcephaly, seizures, poor school performance, intraventricular hemorrhage, intellectual disability, spasticity, seizures, post-hemorrhagic hydrocephalus, sensory neural injury, hearing and visual impairment, retinopathy of prematurity, strabismus, myopia, respiratory failure, bronchopulmonary dysplasia, pulmonary hypertension, bronchospasm, malnutrition, subglottic stenosis, necrotizing enterocolitis, short-to-bowel syndrome, malabsorption, malnutrition, cholestatic liver disease, cirrhosis, hepatic failure, malnutrition, nutrient deficiency, osteopenia, fractures, anemia, growth failure, social stress, child abuse or neglect, failure to thrive, divorce, other sequelae, sudden infant death syndrome, infections, inguinal hernia, cutaneous scars, chest tube, patent ductus arteriosus, ligation, intravenous infiltration, gastroesophageal reflux, hypertension, craniosynostosis, cholelithiasis, nephrocalcinosis, cutaneous hemangiomas. Medically complex infants can go home with a multitude of subspecialty appointments to help manage existing morbidities secondary to prematurity, for example, cardiology for management of a patent ductus arteriosus or pulmonary hypertension, pulmonary for BPD, nephrology for hypertension, ophthalmology for retinopathy of prematurity, neurosurgery for hydrocephalus, and neurology for history of seizures. The extensive follow can be overwhelming and daunting for families. It is very important that these infants have a primary care provider who serves as their medical home to help coordinate and assimilate the care from all these providers for families. Finally, let us discuss on developmental follow-up. It is well known that premature infants are at greater risk for developmental delays than their term counterparts. The more preterm, the greater the risk of delay. In addition, certain postnatal morbidities, severe BPD, grade 3 or 4 intraventricular hemorrhage, severe retinopathy of prematurity, are associated with significantly increased risk of developmental delays. It is very important that preterm infants are followed and assessed for developmental delay, so that if delays are detected, interventions can be instituted early. It is recommended that developmental follow-up be available for infants born less than 3 2-week PMA, or at a minimum less than 2 8-week PMA and or less than 1 kg birth weight. Developmental follow-up in the United States is most often provided in a neonatal follow-up program for the first 2 to 3 years of life, and in some cases, until school age. Assessments focus on 5 main developmental domains: cognitive development, language development, fine and gross motor skills, social development, and emotional development. Although many assessments exist, the most widely used assessment in the United States is the Bayley Scales of Infant and Toddler Development. In addition, it is important to note that for at least the first 2 years of life, a child's corrected age should be used in determining if a delay exists. Corrected age is calculated by subtracting the weeks born premature from a child's chronological age. In doing so, a corrected age accounts for a child's prematurity. Some debates surrounds whether corrected age should continue to be used after age 2 years. Determined that a delay exists, a child should be referred for appropriate therapy to help minimize the delay as the child ages. Federal law under the Individuals with Disabilities Act requires states to provide early intervention services to children less than 3 years old with developmental delay. States vary greatly in how delay is defined and what services are offered. Early intervention is associated with improved cognitive outcomes in infancy and preschool age, but not lasting into school age. Motor outcomes are improved in infancy for children who receive early intervention, but this has not been shown to be a lasting effect into preschool and school-age premature infants, especially those with a history of grade 3 or 4 intraventricular hemorrhage or PVL seen on head imaging, are also at increased risk of motor impairments. Cerebral palsy is non-progressive but permanent disorder of movement and posture caused by disturbance to the developing immature brain. Historically, cerebral palsy had not been diagnosed until 18 to 24 months of age, but current tests such as the General Movements Assessment and Hammersmith Infant Neurological Examination are helping to identify children at high risk for cerebral palsy within the first few months to year of life. This enables these children to access early intervention services and therapy at an earlier age, as well as undergo more frequent surveillance as needed. Children with a history of prematurity who do not show significant developmental delays in the first few years of life are still at risk of later developing learning disabilities, attention problems, and decreased school achievement. Continued screening by their primary care provider may be needed as these children age. Thank you. You can look another topic on my YouTube channel.